a glimpse into where we are at in the Damon system today, okay? So this is more intermediate advanced in terms of where we're at, right? So we're going to close with that just to get your interest up in what we're doing and show you some of the things that we are doing and where we go from here. Okay. Friday, I hope you all can make it Friday morning because we're going to talk about, I think you're going to understand how I figured out what the problems are and how we fix that, all right? So using the Damon system has been an awesome part of my career. I've been doing it for 20 years. I could never look back. We had multiple problems, brackets breaking. We had the D3 clear, where it broke apart. And, we have had all kinds of issues over the years, but it never was enough to make me change or do something different because I had no answer. I mean, this passive self-ligation is an amazing tool, and I love it. So, I got to put this on, and that'll work. There we go. Alveolar bone modeling with PSL, fact or friction. Okay, so this segment came from the AAO in 2017. Okay, so I want you at the scientific session. So I was honored to speak at the AAO for the first time in my career, and we'll tell you a little bit about how that happened. I lectured at University at Rutgers. I was invited by the chairman of the department, Dr. Tom Cangelosi, to speak at a symposium. He invited Dr. Vaden, who is a Tweed. I don't know if everybody knows Dr. Vaden, but he's a very conservative guy. He practices Tweed technique, and he's really a really good orthodontist and a great gentleman. And I spoke with him at the symposium at Rutgers, and it was sort of build old school, new school. So Dr. Vaden lectured in the morning, I lectured in the afternoon. All right, and as a result of that, Dr. Vaden and I became fairly good friends. And he invited me to speak. He was a scientific chair in San Diego, and he invited me to speak there because he said to me that he could not treat the cases that I showed with his technique. All right? So what is dental alveolar development or modeling? Okay? These are the questions. Is modeling alveolar bone the key for conservative treatment? Is substantial modeling possible in a non-growing patient? Under what circumstances will it occur? And are there reliable criteria for a differential diagnosis? In other words, is it predictable when we can do certain things or we can't do certain things? All right? And I already gave you some of the predictable stuff on extraction cases. If you have a high angle case and the incisors over 90 degrees and you have crowding, don't even think about it. You're going to probably have to extract, all right? So some people attempt these things non-extraction, a trial and error diagnosis or treatment plan, and then they get too far into it, and then they're afraid to take out teeth because it's going to extend treatment. So that's a pretty reliable criterion. Look at that lower incisor on the mandibular plane, all right, and extract if you have crowding, all right? This article, I did see somebody, I think it's here. I did see a couple people walking around with it. I don't know if they got it here. But this is an article that we wrote for Clinical Impressions. We actually wrote it for publication, and then the JCO wanted more information or something like that, and we decided to give it to Clinical Impressions at the anniversary issue of the Recoming. So Dr. Barron, who practices in Maryland, is a very good friend of mine. I practice in New Jersey, and I live in Florida. So I only fly up the first week of every month to teach at university and practice with my son, who now he owns a practice. All right. So my experience with functional appliance allowed me to arrive at the conclusion that modeling a bone is possible. All right. This is a case in that article, okay, She was 13 and a half at the time we treated her, class 1. But just look at the arches. Why don't you just pay attention? Look at everything that we talked about today. Look at the collapsed buccal segments. Look at the incisors, which are retroclined. And again, this case is begging to be treated non-extraction, because that is not a normal arch form. We should not be treating to this arch form. This is collapse. You can look at the teeth. You can see them leaning in no matter which direction you look. And that case begs to be treated. Should we treat to the original arch form? And the answer is no. Melvin Moss taught us that in the 60s, but nobody believed him at that point in time. Or was Melvin Moss right? And it's true, he was right. I mean, I know he's right, because we do this day in and day out. We take these crowded teeth that are all collapsed, look at the dentition, look at the buccal segment, know the muscles have done that, and level all this crowding out, and we don't flare teeth. So how do we go from here to here, and we don't see substantial flaring of the teeth? It's because we are uprating the teeth over their apices. That Melvin Moss told us way back in the 60s. That Frankel proved him right with his appliance because it didn't have anything on the teeth. They just moved. And I don't have time to show you any of the Frankel cases, but this stuff is for real. All right, so this is her final records. And this is the size-corrected pictures. Look at the expansion that occurs in the buccal segments when these teeth upright. The canine, again, not expanded. When you look at the canines, you see the buccal surfaces of the teeth in the occlusal photo. You know we can upright those. So that's not tipping or expansion of canines. It is simply uprighting of canines. And all that space develops. So this case is in that article. And how do I know it's relatively stable? I like the word relative stability. There's no such thing as perfect stability, right? But 6.5 years later, without any retention, she didn't have an upper bar on. And did she have a little bit of movement in incisors, a little rotate? Maybe, a slight amount. But it's insignificant in terms of the looks of her smile. You see this lateral rotated slightly. That's why we bond 2 to 2 today. And in the lower, all right, you'll see that there's a little bit of rotation in incisors. Look at the bicuspid that was leaning in. All right, it collapsed a little bit, and a little bit of rotation of incisors. But she looks great. Nothing's perfect, and people are going to age. So 6.5 years later, she still looks great. So what about the following class 3 cases? All right. Is modeling of alveolar bone the key for conservative treatment in non-growing class 3 patients with severe constriction? How about him? He's 18 years old. 2 opinions for surgery. He's 39 years old. Again, 2 opinions for surgery. SARPI plus possible reevaluation for a mandible, okay, or 3-piece maxilla. Okay. Right. So we got to look at the face, the skeletal pattern, muscles, and the dental alveolus. And then on Friday, we're going to talk about EBO. Everybody know what EBO is, right? You might think you do. And everybody knows what ABO is, right? You might think you do. Well, on Friday, you're going to find out different. What EBO means to me and what ABO means to me. All right? So we looked at her face before. Without looking at teeth, you know something changed. There's a definite effect on the aging face, which is positive. The evolution of this thought process is going to start with observation in cases. So in a young lady like this, we didn't have time to look at her case today. But, you know, this is a case that I wanted to extract in. Right? And because she's protrusive, right? And she's of Filipino descent. She was very protrusive, and I presented extraction, and the father refused. Right? And I told him we're going to lose this incisor. I said, we're going to have to at least extract the incisor. And he refused. He said, well, can't we just try it? So he pushed me way out of my comfort zone. And guess what? I put the brackets on. I put a 2x4 in the upper. I put the brackets on this tooth. And I put it on here with not a very good intention. I put it on thinking, okay, well, I might as well get rid of that tooth early on and just get on with it. So I figured this tooth, she'd be walking in with it in her hand, right? 2 months later, it comes back, and I look at it, and the father says to me, how's that incisor look? And I said, well, I don't know. Looks all right to me, you know. So I thought she would have surgery. I thought she would have a dehiscency. This is 2 years. This is at the beginning of treatment. This is at the finish of treatment. Look at the tissue. Remember what I told you? It'll stay the same or it'll get better, sometimes dramatically better. 2 years into retention, I followed her till she was 19 years old because I swore she was going to need surgery. I was going to prove this father wrong. And guess what? He proved me wrong. He was a better orthodontist, a better diagnostician to me. Because when I was in the consultation with her, and I said, you know, your patient's profile is very protrusive. And I was about to say, she looks, you know, her profile's like a bulldog. Thank God he interrupted me. I said, your daughter's face is very protrusive. And he said, well, doctor, we don't think she looks so bad. She looks like the rest of the family. Imagine calling the whole family bulldogs. You know? So, I mean, he was right. This guy turned my career around. He made me change the way I think. Look at that incisor. How does that happen? I mean, I never thought this would be possible. He pushed me way outside my comfort zone. And look at her profile. It got better. Not a lot after treatment, but look what happened as she got older. It still got better. And this is where she is. This is where she's 19 years old. Look at her profile now. I'm not saying it's perfect, but it certainly got a lot better. And I had nothing to do with that. What happened? She grew. Sarver told us about that. Sarver and Ackerman, the fourth dimension. What is the fourth dimension? Time. Don't diagnose and treat your patients to 11 years old. Think about where they're going to go as they get older. That's what time is about. And here she is, 19. Because I swore she was going to have surgery. There's no doubt in my mind she was going to be a surgery. And at 19 years of old, she's still holding beautifully. And yeah, she looks great. Father was right. Doesn't look like a bulldog to me, right? Well, he was right. She's gorgeous. She's absolutely gorgeous. Okay, so remember I said perio. This is what taught me about light forces, these perio cases. Now this case, you can see that she has a fistula here. She's going to need endo. She's got perio, but here's the same thing. The periodontist, we know we're going to lose this tooth, all right? So we have to develop this premaxilla because she's going to need an implant, right? So we got to go in there, and that tooth becomes the sacrificial lamb, right? So that we can get the bone to develop. So we're going to place coils here, and we're going to start to develop the premaxillary area to get this, to have some dental alveolus so that we can put an implant in. So 8 months go by, and you can see that we're starting to develop that premaxilla. We have room for the teeth. And lo and behold, instead of her coming in with the tooth in her hand, it looks better. I said, well, what is going on here? We finished her. Look at that. Who would have thunk it? That's not good English. But who would have thought that that could happen? Torque and intrusion on that tooth. And she never lost a tooth. Never needed an implant. She looks great. So that's the most dramatic one that I've ever had. But we see improved periodontal situations in almost every case that we treat. Right? There's no doubt that this one is the most dramatic, okay? So I show it to you because how could you possibly think that could happen? Torque and intrusion. Positive torque on that tooth, setting the root back, and the periodontist and the prosthodontist are mad at me. Because now that she doesn't need the bone graft and an implant. So they're both mad at me. No. So that's crazy to think that could happen, right? So it comes down to muscles and dental alveolus. We looked at this young lady. We didn't extract because we thought about the face, right? And modeling occurred. That arch totally developed. So we looked at her today. That's alveolar modeling. And we had to do that. You couldn't extract in this case with that face. And we would condemn her to, a dentulous look. The overwhelming, I said this before, first slides in the morning, the overwhelming problems that we treat are dental alveolar. So, therefore, age is not a limitation. Not at all. It doesn't matter if they're in their 40s. You can still develop the maxilla. You can still get development. Modeling in their 50s. And this is a combination of treatment with the prosthodontist. And 70s. I extracted 4 bicuspids in this case. In the 70-year-old. And I sat at the consultation table across from the husband and wife, and I said to her, we can do this. She had a periodontal issue. She had to go to periodontist and get all cleaned up. And we're going to take out 4 teeth. And I made the mistake of saying to her, I really don't know if you want to go through this at your age. And she looked at me like this, and she pointed and she says, young man. I turned around to see if my son was behind me. He wasn't. Me? Young man, I hate my teeth. All my life, I've had these crooked teeth. My kids had braces. My kids went to private school. He said, my husband and I are retired. We have a nest egg, and I want to fix my teeth. I said, you're on. Let's do it. So look at that. Husband was with her every single visit. They were the cutest couple. Every single visit, they came together, except the day she got her braces off. And when she came in to get her braces off, he wasn't there. And I was worried. I said, geez, what happened? So I said to her, how come your husband's not here? She said, oh, he had an appointment with his cardiologist, but he'll be here next visit. I said, okay. We took her braces off. Next visit, she comes in a week later to get her retainer. And I see him at the front desk, and he's like this, waving to me down the hall to the operatory. So I go out, and I walk up, and I go, how you doing? He shakes my hand. He goes, Doc, I got a new woman. and she is. She's just a sweet, sweet lady. So it all comes down to this. So you can create these beautiful smiles. So can life forces be effective to contribute to dental alveolar modeling with adults with severe constriction? Let's look at that first, okay? Now here's a guy who has 2 opinions for Sarpy. He's a trader on the New York Stock Exchange, and he can't do surgery. He's looking for an alternative because he can't take that time off from work. Wall Street is crazy, okay? So he comes in, and in this case can teach us a lot. When you look at this, and you look at that severe constriction, he's obviously got a blocked out lateral, but how is that arch collapsed so badly on that one side? Okay, I want you to really think about this. Okay, let's look at this. There's 2 opinions for Sarpy, right? How does a suture not grow on one side and grow okay on the other side? This side's not so bad, right? It's collapsed a little bit, but look at this side. How could that be a sutural problem? What did I say about dental alveolus? Maybe he had over-retained baby teeth and the teeth erupted lingually. Maybe they collapsed and blocked out. But it doesn't make sense that could be a skeletal problem, does it? When you think about it logically. Because the suture can't grow on one side and not grow on the other. Correct? Has anybody ever seen that in the literature? The suture grows. So to me, this should be treatable. He's got a great skeletal pattern. We know he's got good muscle, so he's got a horizontal type growth pattern, right? The line falls way outside the skull. We should be able to push against those muscles, and that bone just can't not grow on one side. So something else caused this. The etiology, I don't know what it is, but I'm guessing that we can treat this. So we talk about getting the wisdom teeth out, and we treat about developing the arch. He was a great elastic wearer. We treated him in 21 months. Look at that arch. How do you do that without surgery? It's just modeling. He looks great, doesn't he? So that brings us to Sherry. Sherry is a whole different story. Sherry is going to be treated with, she's got bilateral crossbite. She's got a constriction on the other side that's worse. We're going to treat her with Damon, and we're going to use Excelodent. So let me switch off to Sherry. If I can find my mouse. There it is. Okay. Now, this is Sherry. Sherry, there's a story behind Sherry, too. Sherry's 55 years old. She's got this collapse. I want you to look at this. See this? She's got a half a face, right? My wife was talking to her for years to get braces, because we always look at this smile. This is my wife's best friend. Okay? She's got a half a face. She comes in, she finally decides to get treatment because her incisor is starting to overlap. And she said, my front teeth are starting to look like my mother's. Are you kidding me, Sherry? You got a half a face and what was that? And you're worried about, I think that was Sherry. She's after me. I said, you worried about this, right? So her and her husband come in. I tell them what we can do. Right? And I said, I show her before and afters. Sherry has a high angle, though. Okay? Different animal, right, than Robbie. She's collapsed on the opposite side. So this is a high angle case. So we got to look at muscles, though, too, don't we? Remember? So this is Sherry. Very high angle. But what do you see with the lips? What do you see with the incisors? Don't throw the baby out with the bathwater. Because people look at this and say, high angle, oh, can't treat this without extractions. But look at the muscles. What tells you about the muscles? The dentition. The incisors are very upright. Right? That's Robbie. That's Sherry. But look at those muscles. I can push against them, even though it's a high angle case. Just got to be careful. Go slow, right? But Sherry says, this is a low angle. This is also a high angle. But not as good as muscles, right? Whole different ball game than Sherry. Okay. So that's why you got to think about muscles. And the muscles are given away by the dentition. I can't say that enough. Look at the teeth. Look at what happened. Look at the collapse. It'll tell you what kind of muscles you got. Okay. So her lower incisor is at 87, upper incisor at 84, 85, right? So those are good positions. I can push against those. I can let those teeth come forward a little bit. Profile. Oops. What does that picture tell you about her lips? Half a face. And she's worried about the two centrals. Go figure. What motivates people is amazing to me, right? And I'm telling you, for at least 8, 9 years, my wife was after her to get into treatment. So here's the conclusion. All right? Look at the crossbite on this side, the opposite of Ravi. She's got a crossbite tendency on both sides. But you can see the collapse, right? So she's got really strong buccinator muscle, all right? That's what you're looking at. Look at this, and it's worse on this side. You can see more of the surface of the teeth on that side. So the opposite side of Ravi. But the skeletal pattern's not as good. But the muscles are good. So Sherry concedes to go ahead with treatment, but she says this to me. All right, Bogdan, you got 1 year. I said, 1 year? Are you kidding me? With that case? I said, well, then we're going to use Excelodent. I said, we may use Propel. But we didn't use Propel. We used Excelodent. And she was religious about it. I said, you got to wear this thing. All right, so you know what Excelodent is. It's soft pulse technology. In my opinion, I haven't used a lot of them, but I think the ones we've used, it's been effective. The reason we don't use a lot of them, I would love to use it in every case, to be honest with you, but patients in my area can't afford it because that's on top of braces, right? So Sherry paid just what it cost me for her Excelodent, right? So I think it's effective. That's her husband, Joe. That's the FedEx Cup for any golfers out there. All right, he's an official, PGA official, so he does tournaments all over the state of Florida. So I got to go to this golf thing in Orlando. They have a big show. All right, so I put the brackets on her, all right, and Madison is her granddaughter, all right? And this is why I tell you to take pictures of your strap-ups to show your patients. So Madison looks at her teeth when she comes home. Right? She says, Grandma, does Frank know what he's doing? Honest to God, that's what she said. And she calls me up to tell me that. Sherry calls me up and says, the braces, she says, your braces are all over the place. Well, I said, you know what? Tell Madison that they're all over the place because your teeth are all over the place. I said, if the braces were straight, your teeth aren't going to move, right? So that's what we told Madison, right? But that's the observation of a little kid, right? So when you want to show pictures of a case and show how really bad it is, show them with the brackets on. Because when you look at it without the brackets, it doesn't look anywhere near as bad, does it? So it's an important selling point in your cases. All right, so we start a shorty elastic on this side. And again, you know all the reasons, right? All right, we got class 2 on this side. We want to erupt this bicuspid. We want to keep the molar upright. I talked to somebody from Singapore at break. You got to keep that molar upright. It will dump on the light round wires. So put the shorty elastic on. All right, I don't need one on this side. Not as big an issue. Instead of 8 weeks, in 4 weeks, we went from 014 to 018. So I told her when we adjusted, she lives in Florida. I live in Florida. So she came up. I go up once a week. She would come up, and she was home for the summer months going into the fall. So we were able to do a few visits in the office before back in Florida. I did 2 of her visits in my kitchen with my wife holding a flashlight, okay? And you'll see what we did and how we treat her. But I told her, I said, go home and let Madison look at your teeth, see what she thinks now. This is only 4 weeks. And I moved to an 018. So, I mean, that's an opinion of one case, right? But Excelodent, I don't think I've ever seen teeth move that quickly, right? So we moved from 018 in 4 weeks. And that staining that you're seeing there is from Crest, what is it? I put that on the slide. Pro Health. It has stannous fluoride in it. So some patients react very badly to the tinine and stains. So we had her go for a cleaning. I thought she was drinking a lot of coffee. I said, Sherry, how much coffee do you drink? She comes in. Look at this. She's a fanatic toothbrusher. And she's getting all this staining. So that was Crest Pro Health. stannous fluoride that was staining the composite and her teeth. 1425, remember this is the class 2 side, so we have the one class 2. We go from now 8 weeks, we put into 1425. So we did 4 weeks of 014, 4 weeks of 018, and we move right to the 1425. So we cut the time in half to move to our wire sequence with Accelerate. Now, Sherry, you can see a Fanatic toothbrusher. She's brushed her enamel away in Denton. So we have her using a soft toothbrush only now, and she's going to get restored later, right? But you can already see that she's coming out of crossbite. So we start a class 2 on this side to help this bicuspid up. And we place the 1425s in 8 weeks. So that's today we put look at the response to the arch. She wore crossbite elastics, and she wore the one class 2 at the first visit. And we went to bilateral class 2s at the second visit, all right? But full-time crossbite elastics quail. We get to rectangular, I move up to rabbit on the crossbite elastics. Okay. A rabbit, I think, is 3 ounce or 3.5 ounce on the crossbite elastic. So 4.5 months, 1825. She's up for Christmas break. She comes up from Florida, so we're able to move her wires up to 1825s. So at 4.5 months, we went to 1825s. This is a wire that I had a little bit of problem with. As you can see, we had to get this through. I did put insignia on her, too, by the way. So we had insignia on there to accelerate. So in other words, I set her case up on computer. So she did have, I forgot to mention insignia, except for the clear brackets on the front. That's not insignia. I had to put them on, right? She had to have clear, for sure. So I was in no, and the rest are insignia, all right? So we're able to engage this second molar. But look at that thing coming out. Now, you got to get on second molars in the upper arch, if you can, at the very first visit, okay? Most times they're going to help you because the second molars usually in crowded cases come out buccal, so they'll help the arch expansion. In her case, it was a little bit of a detriment. So let me go back one slide. 2 slides. Where am I? Nope. I'll show you the next. There it is. So you can tell insignia because the brackets are all upside down. They look like they're upside down. That's what insignia. Okay? So the next visit is in February. This is done in my kitchen. Okay? We go to 1925 plus degree set. What did I tell you before earlier today about positive set? What does that do to a constricted case? Constrict, it works against you, right? Negative set allows the arch to go this way. Positive set against you. So crossbite elastics are essential. So she's got to wear those crossbite elastics to maintain the crossbite correction. And she's out of crossbite now. But you got to use crossbite elastics when you put positive set in. I mean, she needs torque. So I've got to torque her. And then the class 2V, and this is what I mean about 2 ounce elastics. We use 2 ounce elastics, but that's not 2 ounces of force when we go to a V form. Because we stretch it from the molar, put it over the hook on the canine, and then back down to the body. So that's more than 2 ounces. It's a 2 ounce elastic. It's a parrot. We never moved above parrot on her, but that's not 2 ounces of force. If you stretch the elastics 3 times the diameter, that's what the manufacturer bills it as 2 ounces. If you stretch it 4 or 5 times the diameter, the force is getting greater. Okay? So remember, 2 ounces, 2 ounce elastics, not necessarily 2 ounces of force. But we're still keeping it light. I doubt if we get over 3 ounces, even with that stretch. Okay, So that's our class 2V. That's our formation. I want you to take a look at this canine. Remember where it was? Look at this. Shorty elastics are huge. I mean, you get that early correction. You know, we're already in class 1. Okay, now, you see the chain is under the arch? Another thing about positive torque wires, right? If you don't chain, what happens to the front teeth? They're going to flare, and spaces are going to open up. So negative set does not require a chain. You can use it if you have spaces, right? But positive, you'll always have to have a chain on because your teeth are just going to flare or space, all right? And neither one of those are good side effects, especially for your wife's best friend. She'd kill me. Okay, positive set, 20 degrees in the top, 17 TMA in the lower. She came back in June for a pan repo. So you have to come back. I can't do that in my kitchen. Okay? So we did pan repo in the office. But look, it's looking a lot better. Now I'm at 10 and a half months, so I'm under the gun, right? Class 2B's continued. Now, this was me. I did this with a diamond. Why did I do that? Well, you want to get rid of the dark triangle as much as you can. So I took a diamond and go through there. I do that all the time. All right? So if I have a dark triangle, I try and reduce it, if not eliminate it. So post-repo and post-disking. So I disc those teeth to get them together. We put a coil on with hooks to close the spinal space. And I had her tilt her head so you could see, even though I tilted it the other way, you can see that the arch is definitely expanded, right? So you can see how that's filling out on this side compared to this. "12 months. Did we schedule for a D-band? No. She couldn't make it. So I got an extra month out of her. 13 months. So final records. So you see we got that pretty close. I can't keep filing teeth endlessly. She had pretty narrow teeth to begin with, right? But we got rid of that dark triangle for the most part. So she was happy. And I told her, you always get veneers. And she did do cosmetics for this. I might have those photos. Now, for me, 13 months in this kind of, that severe constriction, never saw it happen before. All right, so I think there is something to Excelodent in the soft pulse technology. I think that it is effective. All right, and the final Ceph will show you that we didn't flare teeth to a great degree. All right, the lower incisor went plus 3 millimeters, right? 3 degrees, rather. Where did it end up? 90. 90.6. You put it on an x-ray, it's 91, right? High angle case, what did I tell you want to be? Around 90. So we're able to keep her within that 90-degree range, and we torque the upper incisor plus 5 degrees. That's from the AO. I had to black out the eyes. I don't know how that got in there. Right? So, muscles, high angle case. A lot of people would throw that out and say you can't do it. But remember, Even though it's high angle, it doesn't mean every high angle has bad muscles. Most of them do. I probably tell you 80, 90% of those patients don't have good muscles if they're high angles, but not all of them. So don't throw the baby out with the bathwater. Look at that last criterion. So it's space, skeletal pattern, muscles, and the muscles are given away by the dentition. Okay, we do have the retention follow-ups. So 1 year later, she got the bonding done on that recession. Yeah, she got that done. And we sent her out to a periodontist first. She had some perio issues, so we had to get her cleaned up before that, right? And she came out looking pretty good. And she's, like I said, fanatic. So I think she'll hold up beautifully. So now you've met Sherry. You can tell my wife at the cocktail party you met Sherry. All right, so let's talk about principles. All right. When you have severe constriction, you need to spend more time in those round wires. Okay? What you saw with Excelodent accelerated that process. But when you have to spend more time in round wires, severe constrictions, severe crowding, and perio. Right? Don't rush it. Let those arch wires work longer. Let them work, because understand that while they're working, the muscle, specifically, must be getting tired again. Can't talk. That tongue is starting to work from the inside. That's what we saw with Frankel's. Right? So give it time. Because the more you push it, the more you'll flare teeth. So don't be in a hurry. Let them work. And, my opinion of Excelodent is pretty high. I've used it, half a dozen times, and I think that it's effective, right? Early light elastic initiated the first visit, okay? Sometimes the second visit, because we haven't completed the whole arch. In a lower arch where we have an extraction site or we have ease present, we don't cross that extraction site until we get to 016 or 018. Don't cross in an 013 or 4 in the lower arch, because it's just going to come out. You're going to have an emergency visit. Right? In the upper, you can cross. Because if you have the second molars on, you can cross with an 013. Food doesn't seem to dislodge the upper wire like it does the lower wire. Okay? So early light elastics, disarticulation, and light forces throughout treatment. That's what's going to give you that modeling. Modeling of the alveolus versus dental compensation. Pure skeletal malocclusion is a minority of the problems that we treat. If you got that, you're doing surgery. You're not treating this with any bracket or elastics, right? And I don't think I've ever had a patient with more screws in their head or plates than this one. That's post-surgery, 1 week. That's her final records. Swelling down. Pretty dramatic difference, right? So, what about the class 3 patients? All right, so this is a case treated at university. How much do we put our patients through? How difficult do we make it? All right. So this is a chart that this is not a case that I treated, and I have the permission of the resident to show you this. All right, take a look at this. Bilateral crossbite, retroclined incisors. Dr. Richard Lee treated this and gave me the records. Wits, minus 8.7, IMPA, ridiculous, right? All right, this was treated with active clip. And they treatment planned it for surgery. Wilco plus surgery. So they're going to do Wilco, do the expansion, then they're going to do jaw surgery following expansion. All right. "12 months. Expander goes in, they do the Wilco. Upper jaw first in the morning. This is at university, so all morning was the upper jaw, all afternoon was the lower jaw. Arch is segmented, they do the expander. There's the Wilco, there's the bone graft, suture. Afternoon. Retroclined incisors. When you have retroclined incisors, there's probably a defect, especially when they're this retroclined. So we learned that we want to put positive torque on those, right? We told you that in class 3s. Right. Did the expansion. Patient is leveled out. They didn't use any elastics. No elastics in this case because they're going for surgery. They're just decompensating. Send them for the surgical consult. And final records in December of 15. 39 months, and the patient quit. Just didn't want to do it. Can you blame her? So what if we could expand our treatment options? What if we could tell many class 3 non-growing patients that there's an alternative to surgery? Wouldn't that be nice? What if we could tell a constricted non-growing patient that we don't have to do surgical rapid palate expansion? Just showed you Ravi, I just showed you my wife's best friend. Okay. What if we could tell a patient they didn't have to spend months in pain or out of work and reduce treatment time significantly in these cases? Here's Stuart, bilateral crossbite, 39 years old. What do we do for him? Again, 2 opinions for surgery. Take a look. What would you do? Okay, so what I'm going to tell you is that we know that the WITS appraisal is more valuable to us in assessing class 3s at university, okay? So I use this when we look at cases, right? So the WITS appraisal here is 5.1. Right? WITS measures, I don't know if you know what WITS is, but it's more a measurement of dental alveolus. Doesn't tell you which jaw is wrong. You drop a perpendicular from the occlusal plane to A point and B point, okay? So that's what you do. That's how you measure WITS. And then it's a millimeter measurement between those 2 perpendiculars to occlusal plane. But it gives you an idea of where the dental alveolus is relative. It doesn't tell you that the maxilla is the problem or the mandible is the problem, but it's more, I find it more accurate than A and B in assessing some of these cases. Okay? Pretty nasty crossbite, right? Now, you could argue, unlike Ravi, who had a collapse on one side, that this could be skeletal, correct? But I don't believe that anymore. Because I know that that dental alveolus is collapsed. I can see it. All right? When you look at the teeth, you can look at that. Look at the lingual inclination of those teeth. Okay? Doesn't mean there's not a skeletal component, but yeah, I showed you what we did in Ravi. I showed you what we did in Sherry. So I believe there's a potential to develop the arch. So, yeah, Ravi was on one side. He's on both sides. But the picture is similar, isn't it? And if you did Frankel's for the number of years that I did them early on in my career, and you saw what happened to dentalveolar bone by just taking away muscles, it gave me a clue as to that these things were not surgical problems. Not in every case. But it took a while before that sunk in. It took about a dozen SARPs and putting patients through hell with that I finally realized that maybe I should try something different. Just like you saw that case at university, that we put them through all that Wilco just to do the rapid palatal expansion. Suppose you didn't have to do that. So we start him. I did Insignia on him. Does anybody know Jamie Reynolds, Dr. Jamie Reynolds? No? You ever heard him speak? He is one of our speakers. This is one of his best friends. He lives in Michigan. Dr. Reynolds practiced in Michigan. He lives in New Jersey, so he's the one that sent me this case. Said, Frank, do you think you could do this without surgery? And I told him, I think so. Okay. Not based on him, based on previous cases. I'm not showing you those yet. Okay, but I will show you the. All right, so initial strap up. We've got class 3 elastic working from the beginning. Now watch this. This is a Parrott shorty, 6-4. But every class 3 elastic is always a longer stretch than a class 2 elastic. Did you ever notice that? When you go from 6-4, look at the amount of stretch compared to you saw the shorties. So I would not use quail here. That's way too heavy. Okay, the quail is a 3/16 elastic, and you're going to stretch that a real lot. So here I go to the 5/16 because the class 3 stretch is a lot longer than a class 2 stretch. So again, always think about light forces. Light forces. Same thing here. Now he's also got crossbite. Can you see the crossbite elastic? Bilateral crossbites, they are quails. Okay, and the class 3s are Parrotts. Molar turbos disarticulate. One of the secrets, if you can call it a secret, all right, got to have those molar turbos on. Control vertical. So we know about the turbo rationale, right? We want to disarticulate. We want to clear the occlusion. We've got crossbite elastics on. We've got class 3 elastics on. So we're asking them to wear 4 elastics. Okay. I didn't do that. All right, so class 3, what I will tell you is that it is more difficult to correct a crossbite than a class 3. So we need to disarticulate them. There are cases in adult treatment that I put a bite plate in the lower arch, put the upper braces on, and wear elastics off the bite plate to help the expand. Let the upper arch start expansion first. All right, but since I've been doing more and more Damon, I don't do that anymore. Right? Most times I start them together. There are some really tough adult cases. You saw Sherry. I did not do that. I wish I would have used Acceladent in him, but we didn't. All right? Because I think that would accelerate the crossbite correction. So it's going to take me longer to correct the crossbite than it is to correct the class 3. All right, so turbos are on both molars. That's the pink triad gel. Three months in, we're starting to see the class 3 correct. Again, you can't get impatient. Just let it work. Now, we're bringing him back. You saw, he was coming back on a monthly basis, but I was just doing observations on him and taking photos. All right, so sometimes we bring him back because that's when I go back up north every month. So sometimes I had him in 4 weeks just to take some photos. Right? So we're not changing wires all the time. All right? Again, Class 3s. But what do I know at this point? 6 months. I will tell you that if you're in these cases, and I will give you the diagnostic criteria, that in 6 months you should know that you're going to make it. 6 months. That's usually the sign. That's what we're going to see in these consistent. I've treated a bunch of these cases now. Okay, so at 6 months we're coming home. Look at this. At 6 months. There's our pan repo visit. This is typically what we do. Now, what would you do with these incisors? Would you repo them? Do you think they're in bad position? Or do you think maybe this is wear and you need to reshape? That's what I'm doing here, right? So I didn't repo any of these. I just did some reshaping because my root positions were good on Pano. Remember, I set this case up on Insignia, so hopefully I did a good job with the software. Okay. I'm not as good as Insignia as Sonia. Sonia Pallet, make sure you hear her. She's here at the forum. She's the best at Insignia that I've seen. She's really, really good with setting up that software. So even in Insignia, I still do repos. You know, don't assume that you get everything perfect because you set up the software. I still do repos with Insignia. I have not done one Insignia case that I have not had to do a repo. But I bet you Sonia doesn't do a lot of repos. She's, like I said, really good at the software. I think she speaks tomorrow, so don't miss her presentation. All right. So now, because I'm still having trouble with the crossbite and with his tongue, and I got a little bit of an open bite, I have to make an adjustment, read and react. So I bond an extra button, and I start wearing a box crossbite to keep his tongue out of there. Okay? So you see this elastic is a box crossbite now. And that's basically to keep the tongue out of there. But can you see what's happening to his arch? It's definitely filling out. Do you see tipping of those teeth? I guarantee you that you start putting heavy elastics on, you're going to correct it like this. Don't. Just be patient. Let it work. The bone's going to go. And the key, I believe, is light force. You will model teeth with light force. You will tip teeth with heavy force. Let it work. Just be patient. And remember, crossbites will take more time than the class 3. Now, look at the buccal segments. They're coming at a crossbite, but do you see those teeth tipped? That's the key. The key, that's why I'm on 2-ounce elastics. Now, with him, we went to 3. We went to Dolphins for 1 or 2 visits. But the key is to bone, to move with teeth, is light force and low friction. And I just can't emphasize enough how incredible the movement is of teeth and bone when you keep your forces light. This canine is a bear, the upright. I couldn't get a steel wire in there. I had to actually go to a 1725 TMA before I could get a 1625 steel in, because there's that much flex on that canine. Here we go. Finally got the steel in here. So I have an upper TMA. I'm going to go to steel. I did the same thing in the upper arch. To the lower arch, I had to go to TMA first before I could get a steel in there, all right, to get the brackets. Again, I don't want to kill anybody. To force that steel in, it hurts, right? $19.25 TMA, $16.25 steel. Now we go to 1725 plus torque. How crazy does that sound, right? In the class 3, got to do it. Just remember the Wilco case. Those teeth retrocline, what did you see? Defects. So I'm aware of that now. You see enough stuff at university that you start thinking about these things. So we've got plus set because I need to get these teeth coming out. I need them to couple. I need to upright these teeth to get out of this case. So there's our box setup. We put the extra buttons on. That's how we're wearing a crossbite, to keep the tongue out. Oh, see I'm there, I'm on 3 ounce. Dolphin 3 ounce. Okay, now this is not something I often do, but he wanted to finish up, and what you're going to see here in this picture is that I segmented the wire here. Now, you got to be very cautious. I don't do this very often to finish a case. I'll talk more about this on Friday. If you do that, you see this box to seat the occlusion? You got to wear the box on the inside and on the outside, because you do not want to collapse this arch. You're trying to close the bite down, but the minute you take the wire out of the posterior, you're working against your crossbite. All right, so it must be inside and outside to do that, okay? Inside and outside to close that. There you can see it inside, and you can see it outside, okay? Very important. We fought very hard to get the crossbite corrected. You don't want to lose that. $16 months. Not too bad, right? For somebody who was supposed to have surgery. Look at the buccal segments. Do they look tipped? Look at the bone. It's vertical. It's teeth and bone moving together with light force. This is true modeling of dent alveolus. I did surgeries on this in the 80s. I did a bunch of them. And what did I tell you? They don't like me. It's tough. Sarpia is a tough surgery. And we're going to let him settle. He's still a little bit open on this side, but I'm not worried about that. Oh, one other thing. You see I bonded the canine. When the canines are out and you finish a case this quickly, whether they're high, whether they're buccal, bond your canines for 1 year to the retainer bar. Because when you bring down canines and you do it this fast, there's a tendency for them to rebound. The ligament has not had time to reorganize. So you got to keep that on for at least a year. Then you can cut the canine off. There's the arch expansion. What happened to the second molar? Constricted a little bit. First molars expanded. So I did a pretty good job on insignia. I could have been a little bit better on this one. But, like I said, the root parallelism is pretty good. Look at the before and after cephs. This is the after ceph with tracing. Here are the numbers. Okay? So the width's reduced by 1.2 millimeters. Lower incisor did retrocline a little bit. Upper incisor retroclined a little bit. What? It retroclined a little bit? How did that happen? I wore class 3 elastics. Torque. Negative torque. So we did put a negative torque wire in there for 3 months, or 2.5 months. What does that do? Helps with the crossbite, right? Negative torque is helping. So don't be afraid to use those wires. Put them in. And in a class 3 it works. Of course we didn't have negative torque brackets on the anteriors. We did this with Insignia. So it was set up with a custom torque, which obviously would have been negative. And then we added 20 degrees to it, all right, to get this. Upper incisor, control it. Remember when I showed you the extraction case? I showed you the occlusal plane change? Okay, which way did it go? I had the numbers up there, right? Occlusal plane. Always the same. It's rotating up. (113 to 111) with class 3 elastics. That's what light forces do. We're not correcting this with dental compensation. We retroclined the incisors here, and I had positive set on that, remember? On the lower incisor, I put positive set on that lower incisor, right? Because I wanted to help upright those teeth. That's a big difference, isn't it? And you can see that the teeth are upright, not tipped. We got, oops. Okay, so how did I know that that was going to happen? How did I have the audacity to take a 37 or 39-year-old patient and treat a bilateral crossbite in class 3 and know I could do that? How could I tell Dr. Jamie Reynolds in Michigan that I could do it? He asked me, he said, what do you think? What do you think our chances are? The reason I told you I could do it is because of this guy. Now, I've shown this case before. Some of you may have seen it. He's 18 years old, all right? He's got a class 3 relapse, all right? He's told by his orthodontist that treated him he needs surgery. He gets a second opinion, he needs surgery. And his father talks to my dentist, Dr. Lilikas. They belong to a Greek church. He talks to my dentist and says, I'm upset, my son needs surgery. Right? He says, well, why don't you come to Bayonne? He lives in Teaneck, which is probably about 45 minutes from Bayonne. Why don't you come to Bayonne and see my friend, Dr. Bogdan? So this is what we decided to do. We're going to extract the wisdom teeth. There's his skeletal. Look at the widths. And look at the A and B. What's the A and B? It's positive, isn't it? In a class 3? Are you kidding me? That's what I'm saying. Width seems to be a better predictor than A and B. That's been pretty well documented in the literature also, by the way. Not just my observation. So Mike is not happy about going into treatment. Come on, smile, Mike. That was about as phony as a smile as you could ever get. So he's got 2 opinions for surgery, and we offer them an alternative. I'm going to do dental alveolar protraction. We're going to put TADS in the palate and class 3 mechanics. All right, we're going to use custom Insignia again for efficiency because he's going to college in August. We're starting him in November. So I got to get the TADS in the palate before he goes to college and start protracting. The objective is to level the steel. All right, this case I got from John Graham. He showed an adult female at a forum many years ago where he protracted the entire maxilla, leveled the steel, put a palatal bar in, and put 2 TADS in and protracted the maxilla to correct the class 3. So that's the treatment plan that I offer them as an alternative to surgery. No guarantees. because I've diagnosed him for possible surgery also. I said, but we can try this. All right. So that's what we did. So we started him out, initial strap up with 2-ounce Parrott elastics. Okay, so we're going to level the steel. 1925 in the upper, 1625 in the lower. We're going to put the TADS in the palate, all right, and then we're going to start protraction. We started him in November, as I said. We got till August before he leaves for college. So 4 months. He's doing a good job. We've stressed cooperation. And by the way, Class 3 patients generally are much more cooperative than Class 2 patients, because Class 2 patients never look as bad. If they look really bad, Class 2s, they got a really retrognathia, they're in MAR or Herbst. Okay? So these little end-on Class 2s are the toughest cases to treat, because you got to convince good-looking people to wear a lot of elastics, because most of them are good-looking, right? They're not facially distorted, right? So 4 months passes, everything's looking good. I'm saying, we can get these TADS in here shortly. And all of a sudden, I'm looking at this and I'm going, all right, I don't get this. What's happening? Here we are, 5.5 months. And all of a sudden, I'm looking at the case and I got mixed emotions. Number one, I was very excited about doing my first palatal TADS and trying this. So I'm looking at this, I'm saying, do I really need to put TADS in this palate? So now I'm a little upset. And then the second emotion is, I look at this and I go, God, how is that happening? Do you see any flaring of the upper teeth? Do you see any retroclination of the lower teeth? I don't. Class 3B. Now, this is going to be a mistake. You see this Class 3? What should I be doing here? At least, right? But I don't have the guts to change that because I have no idea what's going on here. I keep going with my son over here and say, Mark, look at this. I said, remember the case we're putting TADS in? We got 2 of them. I said, what's going on? So he's coming over here. Five and a half months. We put the 1425s in. I messed up again here. 4 months. Somehow I duplicated those slides. There we go. Now we're at 8 months. And now I look at this and I say, man, I am definitely not putting TADS in the palate. And it's inexplicable as to why this is happening. Remember, this is the first time. This is not, I showed you Stewart first because I wanted to compare it to the case that we lost at university that wouldn't do the surgery. This guy, all of a sudden, so I finally went to the V, but I should be on a Class 2V. How does that happen? You don't see the dental compensation. So that's what I'm talking about. When I talk about light forces causing modeling of bone versus dental incompensation, which is flaring of the upper teeth and retroclination of the lower teeth, it's inexplicable that this can go from here to here using 2-ounce elastics. At least it was at that point. All right? What I should be doing now is Class 2V. But you know what? I just don't have the guts because I don't even have a clue as to why this is happening at this point. I just can't see putting a Class 2 elastic on when this Class 3 is working so good. So he's going to college now. So guess what? He comes in with his father. What do you think he wants? He wants his braces off. He's happy. I said, but I can't take his braces off. This side we got to fix this side. So I convinced them to keep the braces on, go to college, and I told them, you're going to take photos. I'm going to go to the Class 2B now. If you see your teeth coming back into an underbite, take a selfie and send it to me, and I'll tell you what to do. So that's the deal. I said, but, you know, he was so happy. His father's happy. And remember, we're only 9 months into treatment, and he wants his braces off. Molar turbos. So here's Thanksgiving break. He comes back off to college. What do you see with the elastic? This is where we sent them off. He's got it the old way. What does that tell you? He went to college. He forgot how to wear the. At some point, he quit on the elastics, right? And then he forgot how to hook them up, and he hooked them up the minute he walked into the waiting room, and he stuck them back the way he was used to wearing them, right? So he went to college. He's not brushing his teeth. His gums are getting irritated. He's wearing the elastic wrong. And I said, come on, Mike. I promise you, you made me promise you get your braces off. And him and his father, I promised we'll take them off in January. That's his winter break. I said, but you got to wear these elastics. You got to wear them right. Now, when you look at the buccal segment, that side looks great. Now, he obviously did wear them the correct way for a while. And then at some point, he quit, stopped wearing the elastics because it never seated, right? And then he comes in with the elastic on the wrong way. So I don't know when he quit, but that's a telltale sign he quit, right? So we put a 10 elastic on, and we sent him off, scheduled him for debonding in January. And we took him off in January. This side never quite finished perfectly, but it was a done deal. Him and his father wanted him off. Now, I'm calling this a light force dental-alveolar response because I don't think you can look at this and say there's dental compensation. Those incisors are not severely retroclined. The upper incisors are not flared. So how does that happen? This was the first case. At the same time, on Friday, you'll see a segment of the case that is coming in 1 month later, female. All right? So these are two patients going on simultaneously that were diagnosed and treatment planned to put TADs into palate. So on Friday, you'll see segments of that case. It makes no sense, right? So something is happening. The bone light. Look at the arch form change. Remember we talked about shaping the arch to what the patient gives you when you come to TMA or steel? This arch changed how? It narrowed down and lengthened. I didn't do that. I just set the arch wire to what we got, right? But look how broad this was, and look what's happened to it. So I didn't do that, not on purpose. It just happened. That's what happened. His muscles did that. So Melvin, in my opinion, Melvin Moss was right. So this was a breakthrough case. 2010 changed everything. We now have about a dozen of these between university and my office. Final Ceph. Look at the numbers. The widths goes down to 2.4. The A and B is now negative. Right? Upper incisor advanced only 1.3 degrees. And the lower incisor went back about 10, 9.5. Pretty incredible, isn't it? In Mike, this is surgery. I thought it was surgery too. We took a shot with. I had a case at university. I'm going to show you quickly. Look at that. Look at the change in his lip posture. And yeah, now he's really smiling, right? He's happy as a pig in a mud pile. Now, I was really concerned about stability, especially that left side, because I never got it finished. So we finally got him to come back 3.5 years later. Relative stability. Side actually got a little better, didn't it? So I was worried about this falling apart on me, and instead it got better. And we took the bar off his canines 1 year. He broke this bar. and he broke the lower bar. So, and he still held up. And I can tell you that he didn't have any retainers. At 3.5 years, we gave him a new retainer to wear. Right. So, 3+ years. Still hasn't brushed his teeth that good since he went to college. Okay, it is 20 after 4. We'll quit. I will see you Friday. I believe there's cocktails outside. I'll be here to take any questions, or I hope you enjoyed it.